4 criteria, and both are worth consulting. I will note that DMID is the book that's intended for our field, and on pages 149 to 151 of that manual, pica is discussed. Here are the keys of here are the keys for diagnosis of pica. DSM-5 identifies persistent eating of non-nutritive substances over a period of a month. DMID goes along with that and says, also note the type. Is it non-nutritive, or is it raw or discarded or mixed? That is, DMID sees raw or discarded food as part of pica. DSM-5, second criteria, eating of non-nutritive substances is inappropriate to the developmental level. Now, DMID says note the developmental level and identify that it can cause serious harm. That is, the pica, the swallowing of the inedible, can cause serious harm. The point here is that whereas DSM-5 is for a psychiatric, it's a psychiatric diagnostic framework, DMID is for our field, and what we need to keep in mind that whether it's appropriate to developmental level or not, swallowing inedibles is dangerous. Okay. Third criteria, eating is not part of a culturally sanctioned or Okay, so who makes a diagnosis of pica? A qualified clinician, that is a professional with relevant experience, for example, a medical doctor, an advanced practice nurse, or a mental health professional with a minimum of a master's degree in psychology, social work, and a license that allows independent practice. This diagnosis stuff is hard. Why am I spending time on it? Why am I trying to sort these things out? Well, a diagnosis is a formal or a hard label, and some of our wonderful agencies and staff have included in their written work on individuals that the person is, quote, diagnosed with pica when the individual may be somebody who chews on items or has a history of swallowing an inedible one time. So I just want to make sure that people understand that when we're saying someone's diagnosed, it's a hard label. And I want to just quickly point out a distinction between clinicians qualified to diagnose versus to treat. On the slide, the information, I've been, if we're having a little, I guess I was a little too soft-spoken before, and now I'm a little too loud. Okay, so my volume is being monitored. Sorry about this. Back to the topic. The same thing, right? The treatment is different work than diagnostic work, and somebody who's qualified to treat is a professional working in our field in an ethical manner, in an area where they have competence and they have qualifications that fit. For example, a master's degree in applied behavior analysis, special ed, psychology, or a related discipline, and they may have a BCBA certificate. So, again, why all the fuss about pica, right? What harm might pica do? Well, it can do quite a lot. It can poison someone. Obviously, if you eat leaves off of a plant and they're poisonous, the person will get sick. You can get parasitic infection, perforation of the GI tract, blockage of the GI tract. That's the one I've seen the most. It's also bad for your mouth and teeth. My wake-up moment on pica occurred when someone whose case I was the supervisor on, the supervising psychologist on, died as a result of pica. And the person was somebody who we had a behavior plan for. The person had a total of 12 behaviors listed on their problem sheet, if you will. This is going back to the 80s. Pica was number 7. It should have been number 1. This terrible event happened in the late 80s when we were all getting used to universal precautions, and latex gloves had arrived. And what we didn't understand was that latex gloves need to be monitored carefully, because if somebody has any likelihood of engaging in pica, the latex glove is in play, and latex gloves can create a very severe blockage and can harm you very badly. This individual died. Okay, so I want to talk about what I'll call this continuum of concern. It ranges from the individuals who never have ingested an item to people with severe pica. Now, of course, if someone's never ingested a non-food item and you don't mouth items, we're not going to be concerned about the person. If the individual has ingested non-food items 100 times and they do it another 100 times if they had the chance, well, obviously we want to focus on them. And then that person kind of in the middle, how concerned should we be with somebody who regularly chews on an item like a washcloth, but quote unquote never swallows? Taking a drink here. Well, I think that the person in the middle is somebody on whom a team should get or may want to get a consultation. They may want to do some special monitoring if the opportunity presents itself. As an example, and this is a graphic example, inspection of the content of their bowel movements, the person, if you're able to do that. And a qualified clinician may need to be brought in to help with a plan for the individual. And I should note, probably like a lot of you, I chew on pen tops, occasionally chew on my fingers, only a little. My point is, a lot of us have oral behaviors that involve chewing on non-food items. It's odd, but not necessarily harmful. I think that we should expect some of the same in the group that we're trying to, the individuals with intellectual disabilities we're helping. So we shouldn't be a bull in a china shop when someone has a chewing behavior, because many of us do. We should look at it carefully and consider what the possible implications are on the individual's health, and what do the facts say? What data do we have? What information do we have? That should be what guides our response, not just the presence of the behavior. Okay, and what about people who we support who don't have a diagnosis of pica but have a history of ingesting inedibles? Well, I want to emphasize the key is the behavior of swallowing inedibles, what we commonly call pica. The diagnosis is not our focus. We understand our first responsibility is to safety, and that any individual who has any history of ingesting inedibles, we need to look at them. It doesn't mean that every such individual needs to have a full-blown quote-unquote pica plan, but they may need that kind of support, or they may simply need to be monitored. People may need to think about what it is that is in the individual's history. Somebody with severe or profound intellectual disability may have a history of swallowing an inedible item exactly once. And if we looked at it carefully, we'd say, well, the person likely mistook this inedible for inedible. An example that comes to mind is someone who swallowed a small ceramic bead, and the staff who knew them best thought that the individual probably thought it was a mint. So people with severe and profound intellectual disabilities are going to make more errors in discrimination, and we need to think about that, and we need a single error or two in discrimination isn't the same as having ongoing persistent pica, though it may need, team members may need to be very mindful of it, and for example not put items that look like food and that are tiny in the individual, but might harm them if swallowed, in their presence. Okay, further down the continuum of concern, DDS, of course we support individuals with a formal diagnosis of pica. In fact, we support a number of them. This isn't the easy end of the continuum, but when the person's need is clear, we know better what to do. We're not doing so much gnashing of teeth about what to do. And by the way, when you're working with someone who's chewing but not swallowing items, or not usually swallowing, has a very rare history of swallowing, or has a very rare history of swallowing items, maybe long ago, someone who needs to be included in the conversation about how do you support that person is the guardian. Because part of what you're doing is weighing out controlling risk, and sometimes when you control risk a whole bunch, you start impacting quality of life. For example, when you start saying, well, we can't have this in the environment, we can't have that. Now back to this slide, the individuals who have a formal diagnosis of pica. Again, it's not the easy end of the continuum, but usually the need is clear. I see two subgroups among this larger group, that is the people with a formal diagnosis of pica. Usually that's somebody who has at least a moderately significant history of swallowing inedibles, and somebody for whom we need to have supports in place. And the two groups I see are those for whom the supports have been thought out, they're working fairly well, and it's sort of a case where maintaining the current supports is okay. The person is safe. Hopefully they're having a reasonable quality of life. They should be working on relevant skills. I'll talk about those in a couple of minutes. And then there's the other group where the supports are just being put in place or they're being refined. And that's a much more active case. That's one where the team needs to be working very actively with a well-qualified clinician who may be helping the team analyze the behavior, who may be helping the team identify alternative behaviors to work on, and helping with safety concerns as well, of course. Now I want to cover some other information, some background information. Who has pica? And I would differentiate pica from what a colleague who I shared a podium with a year ago referred to as foreign body ingestion. The group with pica, these are mostly individuals with severe or profound intellectual deficits. There is another group, some of whom we may serve, who are much more intellectually capable. In our group, they would be folks with mild intellectual disabilities, perhaps borderline intellectual functioning. And the folks who do the foreign body ingestion, that is, these are people who are purposely swallowing items as a sign of emotional distress, and that may include some of our group, but it's generally a different population. But the group that I want us to focus on are those with severe or profound intellectual deficits. That person may also present with symptoms consistent with autism, OCD, depression or mania, or Prader-Willi syndrome. Many of you probably know what Prader-Willi is, but maybe a few of you don't. That's a disorder where the individual, in essence, has a obsessive drive to consume food, and those individuals without a lot of external control are often very, very large. Besides those individuals, there's also two special groups. A few individuals with severe or profound intellectual disability may develop or recover pica late in life. Now, that's not really in the literature, though a couple of cases I'm familiar with suggest that it's something we should keep our eyes open to. A case I'm familiar with where someone seemed to develop pica late in life, a gentleman, Al, who had long-term treatment with antipsychotic medication for mood disorder, and he, in his late 40s, early 50s, swallowing got so bad that he stopped being able to ingest food orally. He ended up being tube-fed. And after that, Al, who had always had a good appetite, started to grab, at first, food in wrappers, anything he could get his hands on, and try to ingest it. And so he had this sort of developed pica, if you will. And then another gentleman, someone I'll call Sterling. Sterling's somebody I worked with 25 years ago, had very severe pica. And when I met him, he was wearing a helmet and living in a barren ward at Belchertown State School. This would have been the mid-'80s. And we did some nice assessment work with him. We looked at, did he favor food or non-food? We didn't actually use non-food. We didn't use, for example, oak leaves. We used instead seaweed. We didn't use landscaping pebbles, though he had ingested things like landscaping pebbles. We used kuzu root, which is an African spice, actually a thickener, very much like cornstarch that you might put into a sauce to thicken. And what we did a few conditions. Think of this fellow Sterling sitting at a table. On his left, he has food he likes. Could be carrots, could be sweetened cereal. He liked carrots. And on the right might be this, quote, fake non-food. It was the seaweed or the kuzu root, which I really don't think anyone would like. I do have to mention that some people might like to chew on seaweed, extremely, extremely salty. And then we also had an easy versus hard condition. So the food might be easy to get in front of them, the non-food hard, far away, or vice versa. The food would be hard to get far away, and the non-food, the kuzu root, for example, looked like landscaping pebbles in front of them. What we found is that Sterling favored food, and so we developed an intervention off of that assessment, and that was that he had food easily available to him. That didn't eliminate pica, but it was helpful, and that's sort of how we proceed in the field. We often don't create cures, we create helpful interventions. So over time, Sterling moved to a community setting with an agency with a lot of very experienced clinicians, and continuing to have food available and getting supervision and living in a house where the environment was managed pretty well. He did great. In fact, for 10 years, he had 0 pica. Then, a couple of years ago, he started developing swallowing difficulty, and his diet was changed. Instead of having food that he liked available all the time, he had ground up food, and maybe as many foods weren't made available to him. He lost food, and he may have had more problems with constipation. I should also note it had been 10 years since he had had an incident of pica. Maybe the staff got less vigilant, I don't know. And the housemate mix in the house in which he lived in had changed. It was a little harder. The grouping was a little harder. People had been added to the house who the staff had to pay more attention to. Oh, and the longtime clinician was on medical leave. And 6 months ago he got sick, vomiting, hospitalized. Bits of plastic sheet seemed to be like plastic missing from his mattress cover, and game pieces were removed from his rectum. Also some pills. What happened? We don't know. Something happened when he wasn't being supervised, or wasn't being supervised adequately. He had one-to-one staff. It had been worked down to he had one-to-one staff between 9 and 3. Honestly, we don't know even if he swallowed the pills or if he inserted them himself. I say that because it was pointed out to me that the pills that were recovered from him still had the markings on them, and they shouldn't have been able to go through his GI tract and still have the markings on them. Good news, I guess. The family guardians wanted to stay with the agency. They thought the agency had done a good job. Sterling is back home. He's got more supervision. There's more attention to his ground foods. He's got a bigger variety, and he likes them now. And he's learned an easy way to request more foods. He's using a Big Mac, and he's gaining back lost weight. Also, I got way off there, didn't I, talking about these individuals who may develop or recover pica late in life. And again, I emphasize that because I think this is a group that, as our population ages and changes, we're going to need to pay some attention to. But there's another special group, and that's children with sickle cell disease, also known as sickle cell anemia. About 30% of that group have pica. Okay, how many people have pica? If you've seen the department's very nice Quality is No Accident brochure, you see that our estimate, DDS's estimate, is 9%. Well, actually, it's 9% of those folks we serve who have healthcare records. So it's some subset of 9%. In the professional literature, the estimates vary, ranging from 3 to 6% on the low end to about 25% on the high end. That's kind of a maddeningly broad range. Why such a big range? Well, I think it's because of some of the issues that we've talked about, this pica and pica-like, and then the people who chew. Depending on where you put your cutoff point, I think you can get 3%. I think that's people with severe pica, and maybe that's smaller than that. And then if you include all the way out to people who chew on things, and maybe somebody thinks they have some fiber in some fibers from a washcloth they're chewing on in their feces, and maybe they do, or maybe they don't, then you maybe get up to 25%. And you know what, let's put that aside, because our interest is safety, right, and habilitation, and not so much actuarial data, though that would be nice to have completely accurate data. Now, why do people with ID engage in pica? There's several perspectives in the literature, and I'm going to review them quickly. First, the behavioral perspective. The literature suggests many are motivated by what's referred to as automatic reinforcement. That is, it's sensory-based, not socially mediated. An example, automatic positive reinforcement. You swallow something and it makes you feel good. Automatic negative reinforcement. Swallowing it relieves bad feeling for the person. And for those of you who don't know the difference between positive and negative reinforcement, look it up on the internet. You can find the definition there. And positive reinforcement, you're adding something. That's the positive part. Reinforcement, behavior increases. The negative reinforcement, you're subtracting something, relieving a bad feeling, and the result is reinforcement. You're more likely to do the behavior that led to that. And if it's swallowing an inedible, that could happen. Now, a book I want to recommend. It does a very nice job, well, a chapter in it does a very nice job of reviewing recent literature on pica. And the book is High-Risk Challenging Challenging Behaviors in People with Intellectual and Developmental Disabilities. And it's edited by Jim Luiselli. And the chapter is, it's chapter 9, pages 161 to 175, Behavioral Assessment and Treatment of Pica by Hagopian, Rohleder, and Rooker. And as I said, it does a nice job. It's really with an emphasis on the behavioral literature, but covers other literature as well. It's well worth getting on your bookshelf because it has other good chapters as well. Okay, another perspective on pica, developmental. I think when we work with our individuals with severe and profound intellectual disability, we notice that some of what they do is like people of a much younger developmental age. That doesn't mean that our folks who are 38 are like someone who's 4, but they share some similarities in behavioral presentation and in developmental level. Another perspective is, I guess I'm really sharing here my experience, hunger. The person wants more food, and I would say my experience says it's always sensible to ask if an individual may want more food and to offer more food when someone presents with pica. Another perspective, the health perspective, there's a lot of literature on this. For example, related to nutritional deficiency. A lot of work was done on this in the 80s and 90s. I recommend a chapter, Pica and Mineral Status in the Mentally Retarded. Not the most elegant title, I know. It's in the American Journal of Clinical Nutrition from 1982. Does a nice job of reviewing especially the zinc, copper, and magnesium deficiencies and the possible relationship to pica. I would say that this is an area that has shown a lot of promise, but I don't know of a lot of cases where I've seen, gosh, this guy had pica, maybe significant pica, and getting additional zinc, etc., cured them. I'm not saying that it's not in the literature, but there's not a lot of that. So let's see, other health conditions where pica is associated with. Sickle cell disease, I've already mentioned. History of lead poisoning, parasites, addiction, for example, caffeine or tobacco products. It's rare, but for those of us who've worked in facilities in the past, we probably all know somebody who would dive after the coffee grounds or go after cigarette butts, and I think it's pretty clear that's an addiction issue. And then mental illness, such as OCD, mania, depression, or psychosis. Nice article, Worsening of Pica as a Symptom of Depressive Illness in a Person with Severe Mental Handicap, from the British Journal of Psychiatry in 1993. The lead author is Jawed, J-A-W-E-D. They have some, they do a very nice job of presenting their information, their data. Actually, they don't present the data so much as they present a timeline showing their conditions. It's just a sort of a nice approach, a different one than I'm used to. I guess I don't read a lot of British journals. And then finally, another reason why pica occurs, combination, A plus C, whatever, all of the above. So where do we start? We start, I think, when we're drawn into a case or when we start working with somebody, we try to assess safety. Now, first of all, I want to give a sense of how these cases come to us, and sometimes it's consideration of brand new cases. DDS supports adults, and usually we get histories on individuals who are coming into adult services, and usually those histories are pretty accurate and would mention if the individual has pica, but not always. And sometimes we get individuals coming into services and they're really brand new to us, and they're coming in as adults and they're brand new to this country. I work in the Springfield office. I look at every new case that comes in. We get about 150 to 180 new cases a year. In the last few weeks, we've had 3 individuals, 3 adults from Nepal come in. We don't have very good histories on them. They're all individuals with moderate or severe handicaps. At least that's what it looks like. They're hard to assess. As you might guess, they don't speak a language for which we have a good assessment tool. Other things, safety assessment considerations. Sometimes the person is coming and the individual is somebody with pica. We know that. So the safety assessment, if I'm drawn into a case like that, I'm going to check and make sure that the staff know about monitoring for symptoms of obstruction due to a foreign object. Do they know about primary symptoms, such as an individual starting to vomit or a change in bowel movement pattern? Do they know about secondary symptoms that may not be present initially, such as a low-grade fever, etc.? Another element to a safety assessment is a question I would ask. If the person has a diagnosis of pica or doesn't have a diagnosis but has engaged in swallowing inedibles, is it prominently noted in their record and in key healthcare documents that it would accompany him or her to any doctor's appointment or visit to an emergency room if the person were ill? Of course, we want to find out about the person. This is really the biggest part of the assessment because there can be quite a lot to find out, and it's not, whereas the environment is right in front of us, the person and their history might be less accessible. We might have to ask a lot of questions and do some background reading, etc. We want to know if about the person's pica history. We want to know about relevant medical issues. Maybe they have a zinc deficiency. Maybe there's something that tells us there's metabolic issues that would lead us to say, geez, let's talk to a doctor about this. Maybe there's an iron or zinc or some other deficiency. We want to find out about the person's ability. Some individuals I've worked with with pica have exceptional physical ability. Some are very limited in their movement, confined to a wheelchair. Generally, the latter group is somewhat easier to work with. We want to find out about the person's motivation for engaging in pica and alternatives. If the person is happy to do a lot of things and only engages in pica when there's nothing else to do, well, that should be a fairly easy fix, easy for me to say, right? And then opportunity for pica and alternatives. That's actually where we're looking at sort of the fit between the person and their environment. And we want to look at their supports. Is the person supported in reasonable ways to do things that promote health, including something other than pica? I also always want to know about the person's ability to communicate their interests. I think anyone with problem behavior, we always are going to be asking about their communication abilities. Okay, when we look at the environment, we're trying to figure out, does it make pica more or less likely? Is it in good shape? If there's lead paint around, obviously that's problematic. You and I aren't going to be able to figure out if there's lead paint. If you're in an old apartment building and there's peeling paint, you might want to ask or try to find out about it. Generally, there's very little out there now, but that doesn't mean there's none. Are there things for the person to do? If someone has a lot to do, if they're engaged in things they like to do, generally they're going to be less likely to engage in any problem behavior. And also, is the environment cluttered, dirty, etc.? So what do I do? And some of this I've been taught by others to be very thorough when I look at an environment. Tour the environment. Don't be afraid to look under beds, on closet shelves. Recently, due to a case and some coaching from the regional risk manager, I learned it's probably important in some cases, and so we better do it in all cases, to take the bed apart and look. People spend 5, 6, 8, 10 hours a day in their bed. Are there holes in the bed? If we're trying to figure out, is someone engaging in pica? Maybe something showed up in their feces. Where did it come from? Maybe it came from the bedding. We should look. It's not always reported. I always look to try to find out, I always find out where the latex gloves are stored and how problematic items like latex gloves are disposed of. Assessment of the staff and the team. Are there enough staff? That's usually something to think about. Once in a great while, maybe we'll run across an environment where we say, gee, maybe there's too many staff. I think that's so rare I won't spend any more time on it. But if I saw staff talking to themselves a lot, I might question, talking to other staff, that is, I might question, do we have too many staff in an environment? Do the staff know about the person in Pica? Do the staff follow the plans? Are they vigilant? Do they have some good ideas? And are people listening to those ideas? Are they working together? That is the team working together? Are the staff working, all the different staff working together, and hopefully with guardians and family as relevant? Of course, managers have roles, and those roles may include training staff in a protocol. It may include monitoring staff behavior and giving them some feedback on are they doing procedures accurately. That's something I think we've learned to emphasize over time. An example would be staff assigned to do what we sometimes call a sweep, to look at an environment in a systematic way and see if there are items that need to be removed. And then the big bosses, right? I mean, the administrators, they should be on board with this too. I think one of the things that I've learned from, over time, and is part of the positive behavior support model that the department is going to, is kind of an all hands on deck model. That is, when we have serious problems, everybody in the agency literally needs to be part of it. I'll talk a little bit more about that. Now, we're going to get into prevention and treatment, and the old ways. I don't have medication listed here, and probably I should. Preventive equipment for sure, helmet with face shield, and very barren environments. When I first met Sterling, I mentioned years and years ago, almost 30 years ago, that's where he was at, wearing a helmet with a face shield and in a very barren environment. Let's move to more current prevention and treatment strategies. I'm sort of starting, see, number one, have an emergency plan in case Pica happens. That's not exactly prevention, it's too late. It might be very important treatment. If someone has had Pica, let's say that they swallowed a plastic game piece, it's going to be important that staff know what to do and get right on it. Obviously, you don't wait and call somebody 4 hours later. So it's an important potential treatment, perhaps even life-saving. Another prevention and treatment strategy: work with a qualified clinician and analyze behavior, develop a safety plan, develop a behavior change plan and a teaching plan. And the kind of teaching, the kind of behaviors that you would want to teach might be general life skills, but more likely they'd be alternatives, such as if the person finds something on the floor, they're taught to throw it away, or they're taught to give it to staff. And how do we teach something like that? Practice and differential consequences, and we're doing things to encourage the behavior we want, and we're doing things to discourage or at least not encourage the behavior we don't want. I mentioned a chapter earlier in the book edited by Louiselli, the Hagopian, Rolliter, and Rooker chapter. And one of the points they make, it's on page 168 of their chapter, is that for individuals with frequent and high-risk Pica, an assessment including safe bait items to help analyze the behaviors is highly recommended by them. I agree that in order to get at the root of what is reinforcing the behavior, we need to do that kind of an assessment. Also, we need to manage the physical environment carefully. I referenced earlier the doing environmental sweeps. Often helpful to have a checklist to guide staff through an environmental sweep. Another strategy: offer substitutes, including more food, and make them always easy to obtain. Some individuals seem to have a very strong motivation to mount things, and some of the people who I've gotten help from on Pica cases over the year have included, of course, occupational therapists, who can be very helpful in a lot of ways, including identifying better substitutes, if you will. What might the person be able to chew on that is like an item they seem to be seeking, that if they swallow is dangerous to them, and what we always are looking for are safe substitutes. And finally, we need to be prepared for contacts with medical professionals and hospitals. A case that I've done a lot of work on that I'll mention a little later, went to the emergency room, and at first it seems nobody mentioned that he had pica, and he was sick, and he went home for a couple of days. Happily, he survived. But when someone with a history of pica or any history of swallowing inedibles goes to a doctor, or emergency room, that needs to be mentioned, needs to be prominently mentioned that the person has that problem. What helps? A few cases are helped by addressing mineral deficiencies. It's in the literature, and I've mentioned the. Oh, I've covered up my. Just give me one moment here. Here it is. I've mentioned this before, an article that is really quite good, very interesting. Effects of serum zinc supplementation on pica behavior of persons with mental retardation appeared in the American Journal on Mental Retardation in 1990. That journal has since been renamed the American Association for Individuals with Intellectual and Developmental Disabilities. But it's a good piece of research in that it deals first with a population and then with an individual, and the interventions suggest that for those with low levels of zinc supplementation is helpful. And there are some cases in the literature that show that psychotropic medication is helpful. I've mentioned already the article in the British Journal of Psychiatry on the individual with quote, severe mental handicap who responded to an antidepressant. Interestingly, when they before antidepressant, the person had a higher level of pica. They gave the antidepressant, lower level, took the antidepressant away, higher level of pica. So it's a good article. It shows the right kind of diagnosis and treatment can affect rate of pica, including interventions, including, of course, antidepressants and other psychotropic medication. And there's one case I'm familiar with where risperidol seems to have been helpful, though it's hard to say for sure. What else helps? Most people with pica who I come in contact with need help communicating. And there certainly are articles out there showing that communication is an important skill for all individuals, right? And for people with pica, there's some literature out there. There's an article, Use of Functional Communication Training to Reduce Pica, and it appears in the Journal of Speech Language Pathology and Applied Behavior Analysis. A nice combo. I'm getting prompted. I have a few minutes left. And it's by Napolitano and others, appeared in 2004. And of course, some individuals with pica may need a lot of oral sensory stimulation. I've mentioned that. I see this as going along with the early developmental level. It certainly could have other roots. And for those kind of cases, I don't know of citations in the literature per se. Maybe I'm just missing them, but I certainly find it helpful to connect and get help from OTRs from time to time. Moving on. Management strategies that work. Okay, this is not clinical per se, but this is what managers do, right? They're making sure that the monitoring data that may get generated when someone has pica is used. And that includes, it might include bowel movements, it might include sweeps, fidelity checks, that is, are the plans being run as they should be? Are those data compiled? Are they charted and reviewed by the right people? And are they used for feedback and decision? And I'd like to mention that this intersects nicely with the model, the clinical model the department is going to, positive behavior supports, where one of the expectations is that agencies are looking at data that teams are generating, and they're making decisions based on them. And it may be in a particular agency that there's a house with a couple of individuals with pica, and one of the pieces of data that's being looked at by the agency is sweeps. Are they being done? Are they being done right? And what's the data showing? Are the environments clean? What works? Behavioral assessment. in the domain of behavioral assessment, well, you want to know what the person's preferences are. You have to assess their skills. You want to look at the environment the person is in to see the opportunities for Pica and alternatives, that is the competing alternatives, and support. And an assessment of the Pica behavior needs to be done. I think when you're getting to that point where you want to do that kind of work, it's helpful to be working with someone, with a qualified clinician who knows how to do that. Sometimes those individuals, usually those individuals have backgrounds in applied behavior analysis. Sometimes they come with other backgrounds, but usually it's ABA. And then as far as the treatment, well, of course the person has to have preferred items available. They have to have alternatives. Skill development has to be worked on. I've mentioned some replacement skill kinds of things, such as hand over the, if you find an item on the floor that's not edible, if you hand it to me or put it in the trash, then you get a reward. And I know that's an easy one for me to say, and for someone with severe Pica, the staff may be scared to death to do it. And then there need to be contingencies that address what happens when Pica is present or doesn't. One more mention of PBS. 3 intervention vantage points in PBS. There's universal positive behavior support interventions, and those would include, this is something that's available to everyone all the time. An example relevant to Pica, a clean environment. So an agency, a house might have as a universal intervention. They want to have a very clean environment, and that's something they're looking at regularly. And of course that fits in nicely with individuals who have Pica as a presenting problem, or can. Targeted interventions, that's the second of the 3 vantage points in PBS. These are interventions that are quickly available to anyone at risk of developing or a problem behavior or a problem behavior worsening. An example relevant to Pica, easy access to food. It's a nice preventive antecedent intervention. And then the third vantage point in PBS are the highly individualized plans, and that's something that's available to somebody with a serious problem behavior, and it's where the plan is really addressing their needs. And now I'm getting some questions. I apologize. I think I've spent too much time perhaps on the background, and so I'm not going to be able to review the case examples.
We will post the slides.
The slides will be posted so that you'll be able to see them. So sorry about that. I have mentioned the cases a little bit, and now I have some questions in front of me. So I'm going to take them, read the questions, and I'll give an answer as best I can. First question: do people who eat chalky or fibrous substances, are they considered to have Pica? Well, let's say that the fibrous substance is something like cardboard. That's a non-nutritive. Generally, we'd consider that inedible. A corn husk, I think, probably the same. It's a fibrous element that would be, yes, that would be considered Pica. The same chalky, if you're eating chalk or something like that, yes, that would be considered Pica. Second, do you have a safety assessment you could share? Not quite. I have a lot of questions I ask, and I can share that. I don't have a safety assessment per se, and I guess that's something I was mentioning the other day, that I think that this is a field, or a part of our field, where we're working toward having more solid protocols. But no, I don't have a safety assessment per se that I could share. I do have questions I asked when and I shared a couple of them as part of the presentation. Third, do you find Luvox helpful with people with OCD diagnosis? History of Pica, but none since Luvox. Well, I'm aware of one case in the literature like that. I believe it's the Luiselli case. In 1996, Jim Luiselli published an article in the Journal of Experimental Psychiatry and Behavior Therapy that I believe showed that. So I'm aware of that. I've not worked on a case myself where someone with Pica and an OCD diagnosis responded to Luvox. I should note, in my position, I am not a caseload psychologist, so there may be a caseload psychologist, many caseload psychologists out there who could answer that question a little better than me. Do I know of, next question, do I know of any safe mouthing items large enough for adults? I do, but I know about them peripherally. What I recommend, if that's a question you have, I think it's something that on one level any team can investigate. What you want to be mindful of is, does the item appear safe, and also think about what it says about the person. Sometimes I see teams and they want to get a big teething rings, exactly like you would use with a 2-year-old who had teeth coming in, or a 15-month-old. And that might be what somebody needs and what works with them. We would want something that looked a little different if possible. I would recommend talking to an OT, if you can, an occupational therapist, and getting some advice from that person. Next question, can you comment on the size of items that may be a concern versus items too large to swallow? Boy, I'm surprised at what some people can swallow. So I think any of us could use ourselves as a good general guide, but it's not a perfect guide, because it seems to me some individuals who have a history of swallowing out of the ordinary items have taught themselves to swallow those items, and maybe they have low muscle tone and are more easily can get things down. Certainly these individuals who swallow, I know individuals who swallow bed springs, large hunks of plastic, rocks, the super ball, and they have some ability that most of us don't have. Maybe it's just a matter of motivation. So I don't want to, I don't know. Next question, is pica hereditary? As far as I know, it's not. Pica that I'm familiar with occurs in people with severe and profound intellectual disability. For the most part, the individuals who have that level of intellectual disability, it's not a hereditary problem typically. It may be a genetic problem that is a genetic error, but it's not a hereditary problem. And finally, I'm asked about the references. I've mentioned several, and what I'm told is that those can be supplied to those who've registered, so those are going to be put up on the web. We have a few minutes left. Maybe there are some additional questions.
Okay, we're just going to unmute the phones and see if there's anybody on the phone who has a question.
So the phones are going to be made active, and if somebody, I know some of you have a phone number that you can call into and call in, ask a question, and I'll answer it as best I can.
Is there anybody on the phone who would like to ask a question? Okay.
Well, that's. I guess that's it. Thank you very much, everybody, for listening. And
we're going to pass over to Gail.
I'm passing the microphone over to Gail Grossman. Take care.
Thank you. I'd like to close this webinar by thanking Dr. Fox for an extremely informative presentation and for being our guinea pig with respect to our first webinar. And thank you all who are listening in for taking the time out of your busy schedules to participate. We will post the slides in their entirety on the DDS website so that you can access them at any point. And as noted on the last slide, you can also access additional information regarding this very important topic on the DDS website. One link would be under Quality Assurance and Improvement Reports, where you'll find the latest edition of our Quality is No Accident Brief, which specifically focuses on the subject of ingestion of non-food items. The second link would be under our key initiatives, including guidelines and recommendations to manage risk, where you can find guidelines for the development of plans to manage pica in all settings. Again, thank you all for participating in today's webinar. In the near future, we'll be sending out a notice for our next session with a schedule for December 3rd at 12 o'clock on the topic of bowel obstruction. Thank you.